Okay, so now we're going to go over some medical annual training that you have to have per the jail standards. So we're going to talk about the jail standards as we go through these. First one we're starting with is the inmate pre-screen. Some people call it arrest report. I don't know what you guys call it here, but the pre-screen is before acceptance into jail, health trained personnel shall inquire about, but not limited to, the following conditions, and the health authorities shall develop policies for procedure for acceptance or denial into your jail. Okay, so I assume you know what I'm talking about, and I lost something. I'll find it in a minute.
Don't worry about it, Shane.
So the state says you have to ask a minimum of 4 questions. The arresting officer has to do it, and the person that's accepting them into the jail has to do it. And I think this is very important here, simply because when I worked here the whole month of December, Pike, Jackson, Meigs, they bring you some pretty serious issues at times, and they just want to dump them and run. So, suicide thoughts or plans is one of the questions. Current serious or potentially serious medical or mental health issues needing immediate attention. The use of a taser, pepper spray, other less lethal force during the arrest. And then you always have to observe for signs and inquire about drug and alcohol intoxication or abuse. So the arresting officer is supposed to fill out those questions. The person accepting is supposed to fill out those questions. The jail inspectors, when they come in, they ask to see these so to make sure we're doing them. So it is important that we are doing them. Now, speaking of acceptance or denial, I'm going to give you lots of different reasons why we wouldn't take somebody, and explain 3 critical reasons why it's important that we do this at the bookend or prior to accept them into jail. Okay. First of all, most of the police officers don't have no medical experience. Okay, so therefore they don't want to have to take them to the hospital if somebody doesn't make them, because it takes them out of service. They have to sit there sometimes 3 or 4 hours. So I've had many of them come to the jail and say, well, they were cleared medically by EMS at the scene. That doesn't work, okay? It needs to be a physician, a nurse practitioner, or a physician's assistant, okay? So we don't accept EMS clearance at the scene. A lot of reasons why. They have very minimal equipment on those. They don't have they have EKGs. They don't have MRIs, ultrasound. They don't have CT scans. So you really don't know what's going on with these people at times. So 3 reasons for obtaining medical clearance before taking a person to jail. First, taking an arrested person with urgent medical needs directly to the jail delays necessary medical treatment. Okay? So if it's something that's obvious, we want to take them out before we bring them to jail. Second, it delays the care, and it's more efficient to get it done prior to bringing them into jail. Okay? And third, it reduces legal liability should a bad outcome occur. Okay? Not saying that they bring somebody from the hospital that says they're medically cleared and they put them in a holding cell and they die 2 hours later. It's still a death in custody. However, we try to eliminate that by getting them medically cleared. I know, you guys probably know, that's worked here long. You send somebody to the hospital with a deputy or a road PD, highway patrol, whatever it is, and they're in shackles and cuffs, they're going to send them back to jail as quick as they possibly can, unless there's something that's really out there that they know they have to treat them for. That's the way it seems most of the time. So, I'm going to run through some things that we always consider whether we accept them or not, and there's nothing set in stone that we're not going to be able to take these people. If the judge says they're coming to jail, eventually they're coming to jail. We know that. But if there's any way to get medical clearance on some of this stuff, I would prefer we do it prior to bringing them into jail, because it does reduce the liability on some things. First thing, which hopefully this never happens, but uncontrolled bleeding or a broken bone that's obvious, a compound fracture, the bone sticking out. I've never seen somebody try to drop somebody off at jail like that, but obviously it must have happened or I wouldn't have this literature. So we don't accept anybody with uncontrolled bleeding, broken bones. If they were involved in a motor vehicle accident, a lot of jails have it in their policy. They have to be medically cleared before they come to jail. I don't know what your policy is, but
We've recently, that's not in our policy, but we've recently developed a practice because a lot of folks are arresting drunk drivers who crashed out. They're scraping what's left of them off the street,
Right.
bringing them to jail, and it's caused us some problems.
Yeah.
So
I always recommend anytime there's a motor vehicle accident, we get them medically cleared at the hospital prior to bringing them. And we'll go over some of that as to why. And if they were involved in an altercation, 100% of the time, if they were involved with an officer altercation, I send them to the hospital to get cleared. And I'll tell you why. It seems like more times than not, if they say the officer beat them up or whatever, they're going to file a lawsuit within that 2-year window that they have. So at least if I had medical clearance prior to coming, it shows that we did nothing deliberately indifferent. We had them checked out to make sure there was no injuries at the time. That way it kind of reduces the liability of that officer 2 years from now when he goes to court. Okay? Same way, if it happens inside a jail, if there's an altercation, somebody gets pummeled, I'm going to send them out, especially if there's an officer involved, just to try to reduce the liability on that officer. And the last one that they say is if they've been tased, beanbagged, pepper sprayed, or shot. Okay? Some jails won't accept them if they've been tased until they get medically cleared at the hospital. Okay? I've removed many a tasers in a jail, the barbs, so that's not a necessity for me, but if your policy says they have to be cleared, obviously we're going to go get them cleared. Beanbagged or pepper sprayed, I've never sent somebody unless there's something outstanding that I see. I mean, you get beanbagged, you have a bruise and it hurts and you'll get over it, right? If they've been sprayed, we can clean them up here. Okay. Now, however, if somebody had a gunshot wound, I obviously am not going to accept them until they get medically cleared. I have treated many of gunshot wounds in jail, but it was after they had been to the hospital and then sent to jail. Intoxication, first of all, some jurisdictions require them, if they have a blood alcohol level of a certain amount, they automatically get them cleared. Okay. I'll give you some places don't. You don't have somebody that every person that comes into jail don't use a breathalyzer, so you don't always know, right? So if you suspect that they're intoxicated from alcohol, opioids, or other substances, and they have more than one of these issues going on, I would consider getting them cleared. They're unable to walk unaided, so somebody has to physically get them out of the cruiser and carry them into jail. I'm not going to accept them. Okay? Believe me, I've seen it happen. I had to go out to a cruiser because they couldn't get the person out of jail. Or out of the car. So I didn't accept them. I've also went to the cruiser and somebody be unresponsive in the back seat and they tried to drop them off at jail. Not going to happen. They're unable to speak intelligently. That's a questionable call. I mean, really. They've had incontinence of bowel or bladder in the back of the cruiser. There is things that can cause that, but they could also do it themselves on purpose. Confused as to what happened, or they become severely violent. If they become really violent, they're probably not going to see them in the hospital anyways because they're going to be in shackles and cuffs and 4 or 5 guys holding them down. So those are all things that we consider. Serious medical complaints such as seizures, difficulty breathing, chest pain, abdominal pain, confusion, fever, evidence of lice, scabies, cough, a serious cough, or other potentially communicable diseases. Now, if somebody's having a seizure in the back of the cruiser and they're trying to accept them, and it's a real seizure, I'm definitely not going to accept them, okay? I'm going to send them to the hospital, they're going to do labs and that type stuff, see what their levels are. That way it helps us to determine, the doctor to determine what medications they need to be on and what dose they need to be on. They will fake seizures, believe me, it happens all the time. But it's, you know, if you think it's a real seizure, I would not accept them prior to coming. If they're having difficulty breathing, grab the pulse ox out of medical, put it on their finger. If their pulse ox is 90 or higher, they're probably okay. They're probably hyperventilating, that type thing, trying to get out of coming to jail. Chest pain, as we've seen on there, it is tough to determine sometimes, okay? If medical is in the building at any time and you have a question on somebody, make them come and check them. Take the liability off yourself, put it onto them, okay? I would, if somebody's having chest pains, I'd get a set of vitals, I'd listen to their heart, I'd get all their complaints, and then I would make a determination on what I see, okay? Abdominal pain, raise the shirt, you know, look, see if there's a big knot, a bruise, something like that. push on their belly a little bit is what medical would do to see if, if there's any rebound tenderness or something like that. You really can't see inside the stomach, so if there is something that you think's going on, I'd obviously try to get them cleared. Confusion, lots of people come to jail confused. So that's a very questionable call. However, if they appear to have a fever, I would get a thermometer, and if it's above 102, I'm sending them to the hospital. Simply because they could be septic, who knows what's going on, at least a fever indicates that something's going on. Evidence of lice, scabies, or other potentially serious communicable diseases, you don't have to send somebody to the hospital if you see lice on them or if they have scabies. But what I would suggest is that you put them in a holding cell by themselves until medical can see them, treat them, whatever. Because as soon as you accept them, they get through the booking process and get to the back, and they say it was a women's dorm and there's 40 people back there. Now we're treating all 40 people. So we don't want those people in here until they get back there. At Muskingum County, every female that comes in, head is checked before they go to general population by medical. Now, sometimes that's tough because you don't have very many holding cells and they book in 6 women at the same time. So at Muskingum, there was people trained, nothing against males, but females have probably seen a lot more lice than males because you have kids, you check their heads all the time, that type of stuff. So females would check other females' heads, the officers, and if they cleared them, they could go back if it wasn't medical in the building, if it got too full. But just don't let them back until they're cleared because, like I said, that's going to be a cost on the county. It does a lot of different things. So you only have one female dorm here, right? So if you put somebody back there and they had lice, and now we have to treat all 30 of them, that means any other female that comes in really can't go back there for 7 days until we clarify that it's all gone. So that causes problems. Other medical reasons that we wouldn't accept somebody, and we'll go into these a little more in depth. Cancer that's currently on chemotherapy or radiation, kidney failure requiring dialysis, elderly or infirm. That's the one that it seems like more and more older people are coming to jail, and most of them do have medical problems, so we have to deal with that. I'll go into them again later. Mental health issues. Somebody is suicidal, psychotic, manic, delusional, they're self-harming themselves. That's probably the only way I'm going to send them to the hospital instead of accepting them. If they're in the cruiser and somehow they got something, they're cutting themselves up or something like that, they're going to go and make sure there's nothing wrong. If you send somebody there that's suicidal, they're going to send them back to your jail 9 out of 10 times because they don't have room to house them. And I actually had an ER doc tell me one time, well, at least at jail they have somebody 24/7 to keep an eye on them. They obviously don't know how jail technically works. But so mental health is probably one of the biggest issues you have in jail. Lack of treatment is more than anything the problem. But so I'm going to give you, first of all, again, we can refuse anybody we want at the door prior to getting medical clearance. If the judge says they're coming to jail, ultimately they're coming to jail. So all those different scenarios, I'd say average in my 22 years working in a jail, there's not been more than 20 people a year that I refused at the door. Okay, so most of the stuff we can take care of, but some things need to be addressed prior. And a lot of times, if it's a true emergency, they've already had that done prior to coming to jail. Hopefully. One time, this past December, I was here and I was leaving. It was like 7 o'clock at night, and Pike County brought somebody here. I couldn't get him even to answer my questions in your little holding area before they bring him in. And he told me, once I got him to respond to me, he was telling me all these different drugs he's been taking, how much he takes and all that. Okay, he's not our inmate yet, so I told them they need to go get him medically cleared. Well, you know what the woman said to me? I wish we'd have waited till you left shift. That's what she told me. I just looked at her. But anyhow, they took him clear back to Adena and brought him back. So when I come back the next morning, he was here. He's laying in a holding cell, sweating profusely, could not set up. I called and told them they needed to take him to get medical clearance. They took him from here. You probably know this. They took him from here. They never brought him back. They tried to take him to Fayette because I told them we wasn't housing him until he got cleared. I actually called Fayette before they got there and talked to the jail administrator. And he made them get medical clearance before they accepted him. And I don't think he ended up showing up back at their jail. But because they don't want to deal with it, they try to pass it off on you. And Pike is really bad because they have no jail, so they don't have any of that experience. That's the problem. So I'm going to give you 8 different reasons to look for that any way possible, if we can get these people released, even if they're accepted, that we can get them released from jail, because they're going to cause lots of problems for not just medical staff, but jail staff, because when medical's not here, with your annual training, you're medically trained so you can take care of this stuff. So a lot of this stuff you would have to take care of yourself. We don't want somebody in jail that has an IV port. Obviously, if we have to keep them, we're going to put them in booking by themselves. But if they have an IV port, believe me, people get things in jail they're not supposed to have. They could have a syringe with them, be shooting who knows what into that IV. We don't want that. Okay, somebody rips it out, we have a bleeding issue. If they're on IV medication, if you don't have an RN in the building, the LPNs can't push IV meds. So even if they have the meds with them, we still have to take them to the hospital every day for their IV treatment. Okay? If they had a fresh trach, means I always say within a month and a half, 2 months. If you've ever seen one, there's lots of draining, gooey, oozing stuff from them. They have to be suctioned quite frequently. Okay? Probably don't even have a suction machine here. So when medical's not here, if we did have one, who's going to do the suctioning if the inmate can't themselves? You guys. So you don't want those people here. Sign that to her. Give her a siphoning hose. Give her a siphoning hose or a straw. And if they're on peritoneal dialysis, and they have to have dialysis because their kidneys aren't working right. So we're having to transport these people 1, 2, 3, 5 times a week for several hours at a time. Take somebody out of service, costs money. Okay, we don't want those people here. If they're non-weight bearing of 2 or more extremities, so they can't walk, they can't use their arms at all, what's that mean? We're going to have to take care of them. I'll give you a story of Muskingum County. It's been a few years back. 25, 26-year-old guy, about 200 pounds, has no use of his legs. He can use one arm. He's in an electric wheelchair, pins his mom against the wall. She calls 911. They arrest him for domestic violence. Okay? She wouldn't press charges, so the state pressed charges because she loses his Social Security. He was in our jail for 6 months. Okay, we have 1 nurse a shift, 1 nurse a day, and they were now they're 12-hour shifts. So 3 days a week, I had to bring extra scrubs and a pair of rubber boots. I rented a Hoyer lift, which looks like a motor lift, hooked him up, and I'd have to physically give him a shower 3 times a week and get in the shower with him so I could bathe him. Okay? Yeah. They wouldn't release him. He couldn't wipe his own rear end. He couldn't pee himself. So you had to do everything for him. Fortunately, one of the COs that works there worked in a nursing home, didn't have a problem with it. So when medical wasn't there, he's the one that always got stuck with it. I mean, yeah. So after about 3 months, I went to the sheriff and said, listen, he's taking up 3 days of my week, every day, every week, that basically I take care of him the whole day. He went out and got somebody cleared through an agency for an STNA that come in and took care of him 3 times a week. So it's very time consuming. Now the kid has passed away since, and his mother did as well. But the guy liked it in jail because he got treated better than he did at home. When he was getting ready to be released, he was in the front waiting area, waiting for somebody to pick him up. His mom pulls up out front. It's like 2 o'clock in the morning when they released him. And the sergeant's there and he's in his electric wheelchair. What's he do? Pins the sergeant, gets the wall, starts hitting him. So the city arrested him. And they OR'd him because they wasn't taking care of him. But so we don't want those people in here. If they're tube feed, so they have a stomach tube that they can feed themselves with. If they bring their medicine or nutrition with them, then obviously we could keep them. But if they didn't, and they know how to do it themselves, because we wouldn't want to put you guys in that situation, we would keep them as long as we had 24/7 medical coverage, or whenever he needed to be fed, we had coverage here. But if he doesn't have his medicine or his nutrition with him, say it's a Friday night and we can't get the nutrition here until Monday or Tuesday, that's the only way he's getting any nutrition, he's going to decompensate really quick. We don't want him here. If they are total bed bound, they can't do anything for themselves. Somebody asked me, how can somebody like that come to jail? Well, he's the drug kingpin and he got arrested. They could come to jail. I've seen it. Or if they're on hospice, we don't want them people here because everybody knows what hospice is. Even if they come in as a hospice patient and they die in your jail, it's a death in custody. So if there's any way possible to get these people out of jail, when I was here, we had, his last name was Wilson. He needed open heart surgery.
He's still here.
He went twice and got released, but refused to have the surgery, so he's now back in jail. So, he's a ticking time bomb pretty much, but you got to do what you got to do.
He got sentenced to 6 months.
Here? Nice. Hopefully he takes his meds and it makes him last until he gets out of here. Now, that is the pre-screen. It is very important that we answer the questions and all that. I was at Fairfield County, and an officer, I was with the jail administrator, we were doing something out of the building. And I get a call he gets a call from Circleville PD. They took a guy to the hospital. He was on a warrant from Fairfield County. Took him to the hospital because he went unresponsive, a drug overdose. He goes to the hospital, they give him Narcan, and he runs. Okay? They pick him back up, and they're en route to Fairfield County to bring him. And the officer calls and said, hey, I'm bringing so-and-so to your jail. I just want to let you know, I took him to the hospital, they give him Narcan, and he got up and ran AMA. And I caught him, now he's en route, but I'm stuck alongside the road because he went unresponsive again. I'm waiting on the squad. So they Narcaned him again, bring him the rest of the way to the jail, and en route to the jail, he said, are you going to accept him? I said, absolutely not. You need to take him directly to the hospital and get him cleared before he comes. So they did, brought him back. They did a blood pressure on him, said his blood pressure was fine, he was cleared for incarceration. Okay? When he gets out of the cruiser, he has fentanyl powder clear up the back of his shirt because he had a bag up his rear end and it burst. That's why he was overdosing over and over and over. I made him take him back. So that was twice in this third time in the same 2-hour period that the guy had to go to the hospital. So he wanted to drop him off because he'd already been medically cleared, even though he had fentanyl powder all over him. So we don't want that. But once they get booked in, we've accepted them. And then there's a process called the receiving screening, okay, or the bookend process. I went to the OJAB meeting a couple months, maybe a month ago. It was in January or February, I'm not sure. Because all standards are under review for 2024, they were under review. They did tell us that nothing will change until 2026, so we have a whole year. But this is one I don't know Chris Galley, but I've met him a couple times at jail inspection. He's the new director. He doesn't really understand how jail works because he worked in CBCF. But on the essential receiving screening, it says, health-trained personnel, in accordance to protocols established by health authority, shall perform written medical, dental, and mental health receiving screenings on each inmate upon arrival at the jail and prior to being placed in general population. That's what the standard says. And it gives you a whole list of medical, dental, mental health questions you have to ask every inmate. Typically, it's done by a CO because they don't have enough medical in the building to set up there and do that. Fairfield County does, but they got 15 medical people on each shift or something, so they have a nurse that does the medical bookend. Yeah, it would be nice. But what Chris Galley said was, and I don't know what standard it is on the correction side, but there's a standard that says that they have to be booked in within 12 hours from the time they arrive at the jail. Do you happen to know? I don't know which one it is. So Chris Galley asked me in this meeting, hey, we're considering changing this to say they have to be booked in within 6 hours. Is there any reason why we can't? And he asked me, he said, Shane, why could we not do that? You're the only medical person in this meeting. I said, well, there's a bunch of reasons why it can't happen. I said, first of all, it negates the other standard that you have that says they have to be booked in within 12 hours, so they contradict each other. I wouldn't do that. I said, second of all, there's lots of reasons why somebody can't be booked in 6 hours. I said, I'll just give you an example. If you're a jail that houses for other inmates, for other jails or other counties, and they bring you a busload of 15 of them, and they drop them off, you accepted them all, and then you're at minimum staff in the jail, and you have 4 fights in the next 4 hours, and everybody's responding to that type stuff, there's no way they're all going to get booked in. You know what he said? Sounds like an excuse. That's what he told me. I said, well, I'm telling you, it doesn't happen the way you want it to happen every day. I said, there's other issues as well. Somebody comes in, they're completely drunk, they're high on something, they're very uncooperative, or they have severe mental health issues that they won't or can't answer your questions during that amount of time. He says, well, then what we need to do is offer or try to attempt it several different times. Okay, you could do that, right? But you're still not going to get them booked in 12 hours most likely. So he said, well, how do we fix that? I said, give all the jails extra money to hire medical staff to be 24/7. That was my answer to him. And he laughed. So there's no way to fix it. So anyhow, what they're going to do, the change on this is going to be where it says upon arrival, that's going to be removed, and it's going to say that prior to being placed in general population, which is now going to coincide with the 12 hours. You have 12 hours to book somebody in. But there's going to be times where you seriously can't get somebody booked in 12 hours. I mean, it just happens. And then you will have to deal with that at a later time. But
Seemed to go 2 days before we finally got them cooperative enough and coherent enough to get them booked in.
yeah, I had, it was 22 hours to the exact time of death. But he came from another jail, and he would not, could not, I wasn't there, so I don't know the exact surroundings, what took place, but the guy had been there, and they tried a couple times to book him in, couldn't get him booked in, okay? And then he ended up dying, and that was the biggest issue because he was not booked in. He ended up dying of pneumonia. Our doctor read the autopsy report, and he flat out told the jail inspector he was a ticking time bomb. It wouldn't have mattered if we booked him in the minute he walked in the door. He's still going to die. That's what he told him. But it's still death in custody. So anyhow, once the receiving screening's done, now this jail does it a little bit different. They don't, most of the jails I go to, they print out, when they book somebody in, they print out all that questionnaire. They give you one piece of paper and you print them out yourself here. Okay? But anyhow, so every day we review those. Every time somebody comes in, medical reviews those, see if there's anything pertinent that stands out. So if there is, we try to address it at that particular time, right? Sometimes inmates don't give you the information you need, so therefore you don't have the information until the standard says that we have to do a 14-day assessment, which is another essential. Basically, it asks the exact same questions that it did during the bookend process, for the most part. And at that time is when we find out a lot of medical issues that we didn't catch prior. I do suggest that if somebody is booking somebody in, and I know the piece of paper they give them has 3 or 4 questions. I can't remember what it says for sure. But if there's anything pertinent that your officers think should be addressed by medical, they should probably write it on that piece of paper. So, I mean, if I was here, I left on Friday and come back on Monday, there might be 25 people booked in. All right? It's easy to flip through them pages and miss something. Not that that's an excuse, but we are kind of on the same team, so if they write it down, that gives us another clue that something needs to be addressed. If it's anything that needs addressed immediately, they should contact your medical staff, even if they're not in the building, which would typically be me, because they call me if they have a medical issue, but that's fine because we don't want it to delay care. Okay? So this has to be done within day 14. We try to do them quicker than that so they don't get behind. All right? Now, we've accepted them into jail, we've booked them in. Medications come in at several different times, correct? I know you guys do a very good job up front of counting the medications when they come in, because I've been here and went up and helped you many a times. If an arresting officer brings them, somebody in booking should fill this out if there's not medical in the building. Okay? And I'll tell you, I mean, I can't say that you have to do that because I'm not your boss, but I'll explain some reasons why we do it. So this form is in medical. They might have them up in booking, I'm not sure. Once they bring the meds, we write the name of the medication, the script number, whatever it has on your paper, and how many pills are in that bottle, okay? Even if there's 3 different pills, write 2 green ones, 3 red, 4 blue. At least then we know how many pills were in that actual bottle. We count each number and label it. The reason we do that is so we know exactly what came into jail. Maybe medical's not here for the next 2 days or whatever, okay? At least then we know how many came in the building. Then when we get here, we can verify it. Anytime I came in and I verified it, I'd get an officer to verify them with me because I'd recount them to make sure they were right. But that way, not that your officers would do this, but it would be anybody, if we're not counting them, could take 4 or 5 and put it in their pocket and nobody would know. At least then we have a documentation that 3 signatures are on it. They were this many when they came into jail, okay?
We've started a new thing. If medical's not here and I take them in, I put them in an evidence bag.
And seal it. That's a good idea because that's what we do with the narcs back there that they don't get. And then when they leave, we do the exact same thing. We sign them out to them. They sign it. I sign it. And I have an officer sign with me every time. Okay? Or whoever's picking them up or whatever. And you guys do it the right way. You get a copy of their ID up front, correct? And the reason we do that is because then we know exactly who brought it in. If it's somebody out there, we know them officers, right? For the most part. So we always get a picture ID and make a copy of it so we can keep with the record in case there's anything that comes out of that, we have somebody to go back to. Because I have seen people get charged with conveyance from these sheets. I had a person in jail that came in. This was like 2005. We already had these sheets in place. And he came in, he'd been there 3 or 4 days. Somebody brought in a bottle of Vicodin for a dental problem. At that time, our doctor, if a doctor prescribed it, he gave it to him. Okay? So I called her. It was a female doctor. I called her. She said, yep, doctor prescribed it. Go ahead and give it to him. Next week, I get another 7-day supply of the exact same med for the same person. I call her again. She said, yep, go ahead, give it to him. Week number 3, I get the exact same prescription from the exact same person for the exact same person. I said, this guy's been in jail now almost 4 weeks. He's not seen a dentist, but he's still getting Vicodin for a dental infection. So she told me to call the provider. I called the provider, and I didn't tell him I was a nurse. I just told him I was working at the sheriff's department, so he talked to me. And I said, hey, I got so-and-so in jail, and you've been prescribing Vicodin for the past 3 weeks for a dental infection. And he said, give me a minute. He looked the guy up and said, I don't have that. That's not a patient of mine. He said, do you know who brought the meds? I said, I do. I had a picture ID and a phone number, right? I read the name to him. He got completely silent. He said, that's my nurse. She stole the script pad and forged the doctor's signature. So she got charged with conveyance, writing scripts. She lost her nursing license. She did do jail time, but not at our jail, because there'd be a conflict of interest then. But so that's why we do it. It's a CYA thing, okay? So, but I do suggest that if there's any way we can fill them out, that we do it because it does save a lot of liability. Now, once all the meds are accepted, whether it's from another jail, through the front, through the Sally Port, whatever, then it's medical's job to take care of them, okay? So we'll contact our doctor, say this is what we have, this is, and they'll decide what they're getting and what they're not getting, all right? At that point, there will be a medical chart made, obviously, and then we will make a MAR. It'll look something to this degree. It'll have meds wrote on it with your times. I think your guys' are, help me out.
9A, 9P.
9A, 9P. So it would say 9A and 9P on them, right? Or 2100. And whatever med is listed here should be the exact same name that's on the card or the pill bottle inside the med cart. Okay? At any time, if it's not, so like this says Zoloft and the card says sertraline, if you don't know what that is, you wouldn't know it was the same medication. Okay? It's probably written on the card, but it's probably about that big and it's hard to see. So I always tell them, whatever med is here should be the biggest, boldest letters that's on the bottle or the pill card. That way there's no questions what it is. Okay? And then whatever time it's supposed to be given should always, 100% of the time, have a signature in that spot. These numbers across the top represent the days of the month. Okay? As if you see here, like say this person came in on March 6th, I mark out everything prior to the 6th, put a straight line down, meaning that's when it started. So every time after that, it should have a signature. Okay? If they refuse their meds, it still should have a signature and it should be circled. And then if you have a sheet like this, you write on the back, inmate refused med at this time. So we document that they did or did not take it every time. Okay? If it is like an antibiotic here, I said this started as Augmentin, it's the second one. Started on whatever date and it goes for 10 days, right? If it's after that 10-day period and you're passing meds and that med's still in the cart, do not give it. Because the order is done, now you're prescribing. Okay? Hopefully your nurse pulls it out, but if they don't, make sure you don't give it. But anytime there's a question, make sure you verify before giving it. Put it on hold, call medical staff, and get clarification before you give it so we don't make mistakes. Okay? Mistakes are still going to happen, but we don't want to make mistakes. Always check the MAR compared to the medication itself, because say somebody is on lisinopril 10 milligrams once a day. We've been doing blood pressure checks and their blood pressure is still high. And the doctor increases it to 20 milligrams. We're going to use that same card because it's already here. And we'll just write on the card, give 2 tabs or something like that. And it should be indicated here. Okay? Clear as mud. Every inmate has 6 rights of medications, what we call it. The right inmate, the right time, the right medication, the right dose, the right route, and they have the right to refuse. Okay? The right inmate, you don't have named or badges or something with their picture on it, right? So the only indicator you're going to have is look that person up on the computer, or if you work here long enough, you probably know them because they come back over and over and over. But it will have a date of birth on the MAR. It should always have a date of birth. So you can ask them, that way if you don't know. Anytime I give meds, I'll explain how I do meds in just a few minutes. The right time, basically, if it says it's a 9 o'clock or a 9 o'clock at night med, you have an hour before to an hour after to legally give those meds per the Board of Pharmacy. Okay? However, if somebody's on, let's say lisinopril, one time a day, they left for court and they come back at noon, we're still going to give them that med when they come back at noon, even though they wasn't in the building. Because if it's within, I always say if it's less than 6 hours or more than 6 hours before the next med pass, I'd go ahead and give it. But if it's less than 6, I'm not giving it because I'm basically double dosing them. Okay? The right medication, again, I explained that. Just make sure that you're giving the right medication based on this in the card. The best way to do it would be pull out that person's meds for that whatever times and sort them to make sure they match, pop them out one at a time so you don't make a mistake. The right dose, again, I talked about that. Make sure the dose on the MAR matches whatever's written on the card before we give it. If you don't make the call, and make sure that you're giving it right. The right route, you're never going to be asked to give meds other than by mouth. They're not going to ask you to give shots or something rectally or nothing like that. You may squirt some antibiotic cream or something on their finger, they can put it on themselves, but you're only going to be asked to give meds by mouth. And then, like I said, they have the right to refuse. If they refuse 3 consecutive days, our provider will probably stop it because they don't need it technically. Okay? When I pass meds, I go to the doors, I bring them out one at a time, I say their name that's on the MAR, if I know who it is, make them respond saying yes, that's me basically. I'll always ask them, are you taking everything you're ordered? Because a lot of times they don't want to take certain things. So that way I don't pop them out, because once I pop them out, I got to do something with them. So I pop them out as they tell me yes. I'll put them in a medicine cup. I always wear gloves when I pass meds. I don't want to touch somebody's pills. I wouldn't want somebody touching mine, if that makes sense. So here, I don't know if they're issued a cup. I can't remember. But for instance, if they bring me a cup, I only give them meds with water, because there's a couple reasons. First of all, I can see in it. Second of all, I make them drink everything they bring in their cup anyway, so I just want to have water so I can verify. But anyhow, pop all 4 pills in the cup, I place them in their hand, and then they put them in their mouth, and I make them show me on their tongue that there's 4 pills there prior to drinking the water. Okay? They drink the water, make them turn the cup upside down in case they spit it back into the cup. Okay? After they swallow, I make every one of them show me under their tongue and the roof of their mouth every time. Now, if I'm passing meds to all 4 of you people and she's first, I might make her do, I call it a finger sweep. Take your finger, you sweep it across the bottom of the mouth, across the top of the mouth. If there's something in there, hopefully it dislodges and comes out. If you watch them, I never take my eyes off from them once I give them the pills until I check their mouth. Because they'll do stuff like that, or I've seen people try to spit them back into their hand, all different kinds of things to hoard them. So I always try to double check to make sure they're not doing that. I do that for every person. And I don't always do the finger sweep. I might do her finger sweep and I might do it to Seth, and maybe that's it. Because I better not do that. He's going to check it. I better just take it, right? So I try not to. If I have a dorm that I suspect everybody's hoarding it, every one of them's doing a finger sweep. And the reason I check the roof of their mouth, it'd be hard to hide something up there, right? Well, we sold denture cream on commissary. This woman bought it and didn't have dentures. And it was pink. She lined the roof of her mouth. I don't know how long she had been doing it. And then when you put the meds in her mouth, on her tongue, when she'd tip her cup back, she'd shove them up into the roof of her mouth. And the denture cream would hold them, right? The only reason I found out because one of the other inmates told me, hey, she's taking denture cream, lining the roof of her mouth and hoarding all of her meds. So I caught her. So that's why I checked that. Don't know why they would do it, but they do. If you need the meds, you need the meds. You shouldn't be hoarding them, right? But, so always the same way every time. That way they get it and used to it. They know what to expect every time. If you suspect somebody's hoarding, they probably are, first of all. If you catch somebody hoarding them, make sure you notify medical when you write it on the MAR. Circle it, inmate hoarded meds, whatever. Because our doctor will stop those as well, even if they're life-sustaining meds. If you're going to hoard them, you don't need them until you agree to take them, and then she'll start them back most of the time. But again, if you suspect it, they probably are hoarding it. I was at Lawrence County. I was working that day, and I know 100% there was 266 pills found for one person. Obviously, they haven't done a shakedown in a long time. They took this guy to court. He was on some kind of sex charges. He ended up getting sentenced to 32 years that day. Okay. When they brought him back, they decided to do a shakedown. So he's setting out and booking, and all they did was take his mat, lift it off his bed, and they were right there on a piece of paper. They brought him out to me and asked me what they was. I identified them. There was 266 blood pressure medicine. All the same pill. He took it 3 times a day. So how many days did he hoard it? Several, right? So obviously he was going to try to end it with all those blood pressure pills. So that's why I now say, if you catch somebody hoarding and there's any way possible you can shake that dorm down, you probably should, because if they got caught, they're probably going to go back in there and take everything they already had hoarded. So then we have another problem. But at least then we went ahead and we tried to fix the situation. So now, that being said, we try to do everything within our power to prevent somebody from hoarding meds. Or not hoarding meds, getting the wrong medications. We all make mistakes, we're human. If we make a mistake and we know we made a mistake, Team Health has a form called Unusual Medication Occurrence. It should be completed when you know you did something, give somebody the wrong medications. Okay? However, as soon as you recognize that you give somebody the wrong med, we should, at that time, look for adverse reactions. Are they having trouble breathing? Are they turning red? Collar's not right. Are they getting a headache? They're slurring their speech. They're getting dizzy. Things like that stand out really quick, okay? If that's the case, they're having an allergic reaction to a medication, what's the first thing we're going to do? Get them to the hospital, right? So they can reverse the effects. However, if they don't have any immediate reaction, we're going to grab one of these forms, whether it's medical or COs, and this needs to be completed, okay? It asks for name, inmate name, the person responsible for the incident, and their unit number. It also says that person completing if other than the above. I tell everybody, the only person that should fill this out, besides the person that made the mistake, would be the immediate supervisor. But if I'm your immediate supervisor and you made the mistake, you're going to be the one to complete the operation. Okay? So, and then you put the date and the time, and then it lists several different reasons why we could have had a med error. Okay? And if none of those match, we can write it in. And then it says description of incident. Every jail I've ever been to, if you make a mistake or something happens in the jail, you do an incident report, correct? So I tell them, instead of writing it twice, write C incident report, whatever number, make a copy, attach it here. This goes to medical and that person has to sign it. So, also, if you made a mistake, you should do this in the process of all this. Write the guy's name down, his age, any allergies he might have, and get a set of vitals. And I recommend that you always call medical to let them know that somebody got the wrong meds. Okay? Because then they will give you information of things to look for, or maybe we'll call the doctor and say, hey, this person got this, is there anything we need to look for? And we'll get back to you and let you know. Okay? But this is only done after the fact that there's no adverse reactions. And this is another CYA. Because if you make a mistake, they know it already, because they probably know what they take better than you do. And they're probably going to call the family and complain. They're going to call DRC, and your inspector is going to come down and do an investigation. If we have everything in place, it looks like we did the right thing. We wasn't trying to intentionally hurt somebody. On the other side of that, if a bad outcome occurs, and you go to court, you try to defend yourself, this is documentation that we knew we made the mistake. We did everything in our power to make sure there wasn't any adverse reactions, okay? So that's why we do it. It does sound like we did the right thing, and it makes it the whole lot smoother. Now, if you're passing meds and somebody has, I've seen this a lot. I don't see it here, but I've seen it at other jails. Say we had, as an example, I went to a jail when we took over, and the bottom of their med cart was all full of people's meds that were here in the past, and they used them as stock meds. So your meds are in there. You've been gone for 3 months. She takes the exact same med, but her meds ain't here, so we're going to pull yours for her. That's 100% illegal. Okay? But jails do that. So we don't do that. If somebody's got, I still have went to jails and found they'll cross somebody's name out and write somebody else's name on it. I immediately pull it from the cart and have a talk with the nurses, because that's not what you do. Okay? That's why we have a drug license, so we can house stock medication. So we have that stuff so we can use it. So if you have stock medications, it might not be this exact sheet, but yours is blue, unless he's changed them since I left. They're blue, so they stand out. They'll be attached to every stock med that we have in the building. Okay? So if somebody, say 7 people are on lisinopril, I can use this same card to give all 7 people one of those pills, because it says stock, and I'm signing them out to each individual at the time I give it. Okay? That's why we have stock meds. So if you do give stock meds, make sure you sign them off. And then there is, if there's narcotics in the building, we have to have total 100% control over those. Okay? So if somebody here, which I know because this is how I set it up when I was here after Sandra left, anybody that came in, that's why I got evidence bags from you. If they come in and they weren't approved to be given, I counted them, put a sheet in the med book, sealed the med inside that evidence bag, and I had one of the officers sign it with me, date and time I put them in there. So as long as that seal's never broken, we don't have to physically take them out and count them every day. However, if somebody is on meds every day, every time we give them, we're going to verify the count. Also, we're verifying the count when we walk in the building with the CO. As we were leaving, we're verifying it with the CO that everything's right in there. If there's not medical in the building, it is the jail's responsibility to make sure that those meds are right at the beginning of the shift and end of each shift. Okay? And it should be signed off on. I know they were doing that. I can't say if they're still doing it. They should be, I know. And sometimes they forget, and if I catch it, like when I was here in the next morning, I'd just call them or have them call and say, hey, make sure you sign this off if you give it, because I'll look at tomorrow and say, yeah, it was given, but he didn't sign it off here. Or when they have them on the phone, I'll say, hey, did you definitely give it? Make sure you sign it off. I'll leave you a spot. Just because if a board of pharmacy walks in and we don't have total control, then they're going to be back every other day to inspect you. Okay? We don't want them in here if we don't have to have them. Because I can tell you 100%, if you have them in your building one time. They are going to continue to come if they suspect a problem. We had to do an investigation with the Board of Pharmacy. Some guy was on Xanax and he was on Suboxone. And our doctor looked them up on ORS, which is, you can tell the prescribing practices of physicians. So this guy, the doc said, according to the paperwork on ORS, he has been on Xanax for over 20 years. He didn't want to just stop him. So we weaned him with what he brought in, and we had to continue to order because it was like a 3-month wean. Because he was on like 8 milligrams a day, so he weaned him over a long period of time. But anyhow, the guy said that medical staff was still on his meds, and he called his family, and the Board of Pharmacy shows up to do an investigation. So it was a 6-hour deal. I had to pull every piece of paper for every med. We physically had to show where it was counted every time. I mean, we ended up being fine because they were all logged that they were given. Still don't know if they were given, but they were logged as if they was given, right? So we covered ourselves. The only thing they had a problem with, which really wasn't our problem, we called in a new script for the Xanax during the wean, and we send them on today and we didn't get them to tomorrow. Our order would say today, but the card would say it was filled tomorrow. They said that was a problem. Not really. I mean, but that was the whole issue. So we don't want that if we don't have to have it, okay? At Muskingum County, I mean, we had a bunch of turnover all the time. I'm sure you guys do too. I talked to the jail administrator and said, listen, we need to do some sort of initial training because they have to have annual anyways. So now the new hire at some point during their orientation process spends 4 hours total with medical, a minimum of 4 hours. So they go on MedPass with us one day. We explain all this stuff to them, how to do it the proper way, show them the technique, and then on day 2, we stand beside them and watch them pass meds to make sure they can do it. There's only been one person that I ever said, absolutely, he cannot pass meds.
Do we do that one?
You'd have to ask one of the sergeants.
It's just a good idea because then they have an understanding of why they're doing or what they're doing and how they're supposed to do it. All right. Intox and detox. So we know what intox and detox is, right? They're intoxicated or they're detoxing off of whatever medications it might be. The standard says there have to be protocols in place. We do have all that in place. I'm going to go over what we do. Okay, as soon as they get booked in, if they initiate something that says, hey, I'm withdrawing, or I'm going to be withdrawing, medical should be notified. Whenever I was here, they would call me and say, hey, so-and-so just came in. He says he's going to withdraw. I would see them then and get an initial set of vitals and complete what's called either a COWS or a CWAS. COWS we use for opioids, okay? Any pain medications, that type of stuff that they have an addiction to or withdrawing from. And CWAS is for alcohol and benzodiazepines, okay? The good thing is, COWS, when somebody's withdrawing, they're probably not most likely going to die from withdrawals from opioids, okay? When they die is when they overdose from it. So, now technically it's really hard to, somebody come in and they just used an hour ago, it's really hard to assess them for withdrawals because they're not in withdrawal yet, okay? But at least we do initial set and we get a set of vitals so we have a baseline to go off from, okay? And these are real simple to figure out and fill out, but they are, a lot of it is subjective. There's very few objective things that you can physically 100% get. When I do one of these, I don't go down and ask them every question and give them every possible answer, okay? What I do is I go get a pulse, I write down that number, okay? It asks for sweating, I can look at them and see if they're sweating, right? It says within the last half hour or so. I'm looking at them, see if there's sweating going on. If they're sitting in a chair during the process, I can see if they're restless, if they're able to sit still for that amount of time. I can look at their eyes to see if they're dilated or pinpointed. Body aches, really can't tell if somebody has body aches, right? I don't ask them particularly if they have body aches, I'll explain that. But I can tell if they have a runny nose or teary eyes, and that all represents a number. GI upset, only way you're going to know if they're having diarrhea or upset stomach is if they're vomiting in a trash can or crapping themselves while they're sitting in the chair in front of you. Tremors, I can look and see if they're having tremors going on when I'm talking to them. If they're yawning, I never ask them if they have anxiety or they're irritable, but you can tell if they have goose flesh skin or goosebumps, Okay, so what I get everything on here that I can look at and physically write down a number for, like how severe it is. And then after I'm done with that, my question is to them, tell me what signs of withdrawal you're having. Because if they're truly withdrawing, they're going to be able to tell you what they're having, right? But so if they don't say it, then that means it's a score of a 0. If they say it, then I'm going to base it on what they tell me and what I can physically see. Because why I say that is, if I ask them, so are you having GI upset? And they'll probably say, what's that mean? Are you having diarrhea, vomiting, that type stuff? They're going to say, oh yeah, I've been doing it the whole day I've been here, 70 times a day. Okay? It's always going to be manifested to be bad for them. So, we have a score at the end. 5 to 12 is mild, 13 to 24 is moderate, 25 to 36 is moderately severe, and then more than 36 is severe withdrawal. I've never had anybody on a COWS that scored higher than a 24, personally. Okay? Because I get what I can get from them and ask them a minimum amount of questions, take what they tell me and put it to use. Okay? Tracy, your nurse practitioner, typically will start meds at around the 25 mark. However, we can start them at any time prior to that. I mean, I've started people on meds with a 5 because when I'm doing their assessment, everything was normal other than they vomited in a trash can 3 times in 15 minutes. They probably are in withdrawal, and it's only going to get worse. So there is a protocol in place of meds that they use for withdrawals. A lot of times people get put on it just because, believe it or not, they continue to complain, they manifest things, so we put them on it. They're basically comfort meds. Okay? However, with alcohol withdrawals, you basically ask the same questions, do it the same way, but they require a set of vitals every time. Okay? And when we're doing withdrawal for somebody on alcohol or benzos, if we start meds, there is a controlled drug involved. Okay? Because if somebody is truly in alcohol withdrawal and we don't get the meds started quick enough, there's a very high likely possibility they're going to end up in the hospital. Because once it gets to a certain point, our meds aren't going to be able to reverse it. They're going to have to be put in a medically induced coma per se and give IV meds because they sometimes become violent and they won't take the meds, or if they're not medically in a coma, they'll be ripping out their IVs and that type stuff. Alcohol withdrawals are way more life-threatening than opioids, okay? I mean, people can truly die from benzo and alcohol withdrawals, okay? Opioid withdrawal, early symptoms include agitation, anxiety, watery eyes, muscle aches, sweating. Later symptoms, abdominal cramping, diarrhea, dilated pupils, nausea, vomiting. Those are the things you typically see with opioid withdrawals. They're going to feel like they want to die because it is painful, but they will usually get through it without too many issues. Alcohol withdrawals include anxiety, clammy skin, dilated pupils, fatigue, insomnia, irritability, mood swings, and possibly seizures. Once it gets to the point where they have DTs or delirium tremens, it's to the point that we have to do something immediately because obviously their blood pressure will shoot through the roof and they could stroke out. Okay? Those will start at any different time typically. Typically though, it is they'll start with the confusion of hallucinations, delusions, severe agitation. DTs generally occur within 24 to 72 hours after alcohol consumption ends, but they can appear 7 to 10 days later. Depends their tolerance level. Okay, so anytime that we verify that somebody is withdrawing from alcohol, our doctor is probably going to start meds at that point, so we can try to nip it in the bud before it gets bad. The mortality rate among those that go into DTs, it's a kind of a big number, but it's somewhere between 5 and 25% of those people are going to die. Okay? So we want to address them sooner rather than later. And there's obvious other signs that you can pick up on. Most alcoholics, if they're true alcoholics, are really red under the neck and their face. They smell like alcohol. They'll be sweating. They look malnourished because they've depleted all their vitamins in their body because they're not taking care of themselves. So we also use certain vitamins when we put somebody on alcohol withdrawal meds. There was typically anymore though, everybody's withdrawing from drugs. So that's kind of a better thing because it's easier to treat. But you still have those people from Mayberry that locked herself in the cell, you know. You probably don't know what Mayberry is, but Andy Griffith's show. They had no drunk that would just lock himself in the cell every weekend when he got drunk. But you still have those people, and typically when they come to jail, they've already been here before, so we know them, and we can get them started quicker. One time, I'll never forget this, I used to start work at 5:30 in the morning at Muskingum County. At 6 o'clock, they called me and said, hey, so-and-so's here. He's going to withdraw from alcohol. He's been there several times in the past, and he always withdrawed. Okay? I go up, take everything with him, and get a set of vitals right at that point, right? His blood pressure was 282 over 170. I said, and then he's sweating, like looks bad shape. I asked him when his last drink was. Remember, it's 6 o'clock in the morning. He said 3 a.m. Said, you was still up at 3 a.m.? He said, no, Shane. I set my alarm every 3 hours and take beer to bed with me because I don't want to wake up and withdraw. He said, I drink 3 to 4 cases of beer per day, and if I can get a bottle of whiskey, I drink that too. And I've been doing that for a long, long, long time. I sent him to the hospital. They put him in a medically induced coma, and he was there for 2 weeks. And when he came back, I mean, he wasn't withdrawing no more, but you could tell that he was malnourished, so we had to give him extra food, give him vitamins, and my guess is as soon as he got released from jail, he went right back to doing the same thing. Because people that get to that point, they what I call functioning alcoholics. Okay, I had an uncle that I never seen sober in my life. That's probably why I don't drink today. But he worked every day, but every day for lunch he took beer, and they knew it, and they let him do it because he was a good worker. But he couldn't function if he wasn't under the influence. So that's how there is people out there like that. But what reason I go through all that, if medical's not in the building and somebody tells you they're going to withdraw from alcohol, they're going to withdraw from drugs, according to the jail standards, because you're medically trained, this stuff should be initiated by medical staff or by CO staff, okay? And as soon as you initiate it, call whoever is on call to get directions as to what to do, okay? Now I know we have an agency person in here now, so they might call him some, they call me some still today, and that's fine. And I'll give them the information. But once we have a team health person, that person will be on call 24/7 at all times. But like I said, you can call, if Jacob's having you call him, that's perfectly fine. If you're calling me, that's perfectly fine as well. We just want to initiate these because the jail standard says we have to, okay? And we don't want to delay care and cause deliberate indifference. There's a jail currently. I won't give you the jail's name, but they had a guy come in that was drunk, and he was rejected at the door. They did the pre-screen, answered all the questions, sent him out for medical clearance. He comes back, he is drunk. This doesn't mean that he's going to withdraw, right? Because we don't know how, he's never been there before. You can't really answer the questions because he's intoxicated. So we have to hold off until we can get as much questions as we can. Medical is not in the building, first of all, or we would have probably went and physically checked him at the time he came in. But so he comes back. They did not do the receiving screening again. So that was one ding. They say they have to do that again every time they come back to be accepted. You have to. But he was medically cleared at the hospital, and not on suicide watch, nothing. Just said he's going to, he's intoxicated. That's what it said. Medically cleared, intoxicated. They put him in a holding cell, and he hung himself. The jail inspectors have been harping on them because, first of all, they are wrong. They didn't do the receiving screening again. Okay, that's their fault. But they're saying that as soon as he walked into the jail, that the CWIS should have been started. My argument with the jail inspectors, and I've argued this with them, and I got to go to another meeting with a bunch of attorneys because the jail was fighting it. Because they're finding them liable because he died in their jail. He did die in their jail, but they're saying because they didn't do the CWAs, that's what their problem is. And my argument with them, as I already told you, is how do you assess somebody that's currently drunk for withdrawals? Even if we did the CWAs on them, and we did them 3 times in that 2-hour frame, that's not going to prevent him from hanging himself. But that's their issue. They're saying, so anytime somebody comes in, reports they're going to withdraw or from alcohol or drugs, let's initiate the process. That way it covers our butt. Now we're going to talk about suicide prevention, suicide checks, all that stuff. Again, that's a jail standard. Suicide prevention, the health authority shall have a plan for identifying and responding to suicidal or potentially suicidal inmates. And it gives you a whole list of things that you have to provide and have mental health see them, all that type of thing. What we're going to talk about is we can't prevent it, obviously, because if somebody truly wants to kill themselves, they're probably going to do it. But when you're booking somebody in, if they tell you they have a long history of suicide attempts, they've recently attempted it, then I might lean on the side of caution if it's recent to have them cleared medical or mental health before I release them to the general population. However, if they said 20 years ago I had a bad night and I tried to kill myself, I'm probably not going to put them on suicide watch. You had a bad day 20 years ago, it doesn't indicate you're suicidal now. But if I'm asking them the questions, they won't look me in the eyes, they don't give me direct answers, their body just tells me something's not right, I'm always going to lead on the side of caution and put them on suicide watch and let mental health figure it out. Okay? Because once they go on suicide watch, the only person that can release them is mental health. Okay? If they do release them, at the time they release them, they should give you something in writing saying that they are cleared for general population or removed from suicide watch, however they word it. If they don't, I recommend that we don't release them from suicide until we have something with their signature on it stating that they are released. Okay? And I recently learned that because we have mental health that comes in the building 20 hours a week. They would say, hey, so-and-so is cleared to go back to general population. They would just log it in their computer that so-and-so was cleared for general population by whomever it was, right? Well, we had a death in custody after somebody was released from suicide watch. And they never give us anything in writing other than they told the officer he was cleared to go. He died. Investigation happens. And the detective for the sheriff's department is doing the investigation. Got a subpoena from court to go to the mental health place to get the records because the jail standard says we have to have them in custody, right? The records in custody. He goes, they refuse to give him the mental health record. Okay, that tells me right off the bat that they didn't complete it. You know what I'm saying? So they refuse to give it to him. So the jail inspector comes back and says, we need to follow up on this. So that was like 3 months ago. I go to the inspection, the follow-up inspection the day he's there, and I pull out all the mental health records because they still hadn't given them to us for like 3 weeks, right? I called her the couple days before and said, I have to have these on this particular day. So I have them all, but they're all 3 weeks old when I got them, and there's still people that had been released since that point that didn't have mental health records in the building saying they were released. So we still are non-compliant. So I asked him, because I called her when he was there, and I said, how do we get these records? She said, because of my degree, I have to have my higher-ups review them and sign off on them before I can legally give them to you. That doesn't make no sense to me. If you can legally release somebody, how can you not give me a paper stating they're released from suicide watch? But she said, they will absolutely not let me do that. So, how we fixed it is when she released, all of our suicide checks are on paper. Okay? Not the key fobs. We're old school still, they sign them on paper. So when she released somebody from suicide watch now, she has to sign the date, the time that she released him from watch, put her name and credentials on our paperwork so we have it in a chart. At least we have her name that she released him. But I don't understand because there are patients, her patients that's coming in our jail currently. I don't understand because of continuity of care she can't release them. I think they're trying to hide something. That's what it sounds like to me. Because every other jail I go to, mental health gives them the paperwork before they leave the building. So just make sure you have paperwork before you release them. So characteristics of the jail environment which enhance suicidal behavior. Fear of the unknown. Maybe it's the first time they've ever been in jail. The authoritarian environment. They don't like somebody telling them what to do. They feel they have no apparent control over the future. They're isolated from family and significant others. Maybe shame of the incarceration, or just a dehumanizing aspect of being incarcerated in general. I mean, it is kind of dehumanizing, to tell you the truth. Potential suicide predisposing factors. Recent excessive drinking and or use of drugs, loss of stabilizing resources, severe guilt or shame over the offense. Maybe it's a same-sex rape or threat of. Current mental illnesses, poor physical or terminally ill. Approaching a breaking point, emotional breaking point, or they had a long history of suicidal behavior. Those are some of the factors that would maybe prompt somebody to attempt it. High risk periods, the first 24 hours of confinement, when they're withdrawing or they're still intoxicated would cause that. Maybe they have a trial or sentence coming up that they don't want to have to go through it. So impending release, they're afraid to go out in the real world. If they're going to do it in jail, they say typically it's done when they have decreased staff supervision, which means holidays, weekends. Okay? They get bad news from home, or they had a bad day in court, or they lost a significant other, a spouse, a child, grandparent, something like that. Signs and symptoms of suicidal behavior. First thing is depression. Okay, depression is the number one reason. Physical signs of depression would be sadness and crying, withdrawal or silence, sudden gain or loss of appetite. Maybe they're have insomnia, mood variations, or become very lethargic. Other warning signs would be, again, intox and detox, talking about or threatening suicide. They've had several previous attempts. They have a long history of mental health illness. They feel like they're hopeless or helpless. And speaking unrealistically about the future, like they're getting out tomorrow and they're going to prison for 20 years. Other signs would be increasingly difficulty getting along with others, not effectively dealing with the present or have preoccupation of the past, giving away all their possessions, which in jail they don't have a lot of possessions, but it may be their commissary or whatever. They have paranoid delusions with or without hallucinations. Those are the things that you will see. Intake screening must be used to detect suicidal behavior, physical injuries or trauma of infectious disease, level of consciousness and awareness, acute or chronic mental illness, medications taken, and special health requirements, and again, drug and alcohol intox. Those are the things that we need to look for. That's why we do the pre-screen, so we can ask them those questions prior to coming. High potential people, no prior arrest. White males generally would be more apt to do it than females or black males or females. They have a violent or personal crime. They're getting close to court date, or they get a use of a phone call or something like that. Now, once somebody is placed on suicide watch for whatever reason, they have to have checks that cannot exceed 10 minutes. Okay? So, I recommend that we stagger that 10 minutes. We don't do 10 on the 10. 8, 8:10, 8:20, 8:30, because even without a clock, they're going to be able to get that timing down. If they want to truly do something, that's when they're going to do it. So if somebody goes on suicide watch at 7 o'clock, and we walk by them at 7:05 and do a check, that's perfectly fine. Just don't let that next check exceed 10 minutes. I always tell them to break them up so they don't get your timing down. And when they're on suicide watch here during the day, they get to keep their suicide blanket and their mat and all that during the day?
Depends. Sometimes if they're a particularly bad case, we can clear all that stuff out. But we have certain things that we will allow them to have the duration of the time that they're on watch.
Because some jails I go to, Muskingum, if they give them a mat, they give them a Well, when they first go into suicide watch, they get a paper gown from the hospital until mental health sees them. Okay? So I think they bought several thousand for a couple bucks. And it's kind of a deterrent, but we only have so many suicide smocks, so we try to keep them until we know they're going to be on suicide watch. So they get a paper gown. They get one per shift until mental health sees them and says, yeah, they're staying on suicide watch, or they can go back to general population. So if you give it to them at 7 o'clock at the shift and they rip it off at 7:10, they're naked until the next shift. So I don't know if it's a good thing or bad thing, but it might help deter people that's not truly suicidal to be on suicide watch. But once they get seen by mental health, they get the smock, they get the blanket and a mat to sleep on, right? And they never take them away from Muskingum County. They can have them all the time, the whole time they're on suicide watch. Some jails, at a certain time during the day, like 8 o'clock, they take their mat and their blanket, and all they have is their gown. And that's what they get. So if they want to sleep, they got to sleep on the floor. You don't have to provide them a mat to sleep on 24/7. So
One thing we do is on our checks, which ours only occur every 6 minutes, just so we're well within the 10-minute time
Right.
frame, and it breaks it up. If they're sleeping in there, we wake them up.
yeah, I was just going to talk about never, even if you're doing it on a computer and you have a comment that you log, never write sleeping. And I'll explain why. But I never write sleeping. I don't do suicide checks very often, but if I do the same thing. I make them respond to me. Whether I have to open the door and kick their foot and have them yell at me, or yell their name, I make them respond. If they have their head covered up, I always tell them to uncover their head. That way I know they've physically done something, I know they're still alive, right? But I never write sleep, and I've had people say, well, if they're snoring, they're probably asleep. Well, snoring not always a good thing. They could have something wrapped around their neck and they're choking themselves to death, right? But last year in 2024, there was a case of a juvenile in the state of Ohio that for several hours was logged sleeping, and eventually they checked her, and she was dead, and she had been dead for like 11 hours. So that's not a good thing for that particular juvenile detention center. So we never write sleeping. Even if you wake them up, do you know if they were sleeping? Maybe they're just ignoring you. So I never suggest that you write sleeping. Right? Respond to verbal. But anyhow, once they go on suicide watch, they don't get released until mental health releases them. And I can tell you 100% it's not an exact science. But anyhow, just always lean on the side of caution and let mental health figure it out. I'd much rather put somebody on watch and let mental health figure it out than take a chance on doing it myself and not being taken care of. You are free to go.